empowered with the facts and information and tools and various resources that they need. And I'm also author of a book that came out recently called The Thyroid Diet Revolution. So this is a topic that's near and dear to my heart. And so I'm really looking forward to hearing the questions from everyone, sharing the information, hearing what Dr. Holtorf has to say, and basically delving into the topic of thyroid diet and metabolism.
Hey, I'm so happy to have Mary on and working with us, and she's working with us on the National Academy of Hypothyroidism site, which really the goal for that site was to put out information, evidence-based, that because some people go to their doctor, and the doctor says your thyroid's fine, which we're going to talk a lot about tonight. And then they'll say, no, I think I'm low, and they're just, nope, the TSH is normal. So, and so we really want to put, a lot of it's technical, but go ahead and take a look at the site, and you can see, there's hundreds of studies showing that the way we're diagnosing and treating thyroid in this country isn't correct. But it just, things move very slowly. Once doctors kind of have it in their head the way it is, it's so hard to change. And we'll talk about that as well. So basically, is your thyroid making you fat? It's, so many people come in, very hard to lose weight. They've tried, how many multiple diets, and it just doesn't work, or they'll have temporary success and gain the weight back. And people say, my metabolism is shot. You go to your doctor, oh, yeah, right, sure, just stop eating and exercising more. We'll talk about when people say your metabolism shot, it likely is. And why is that? And if you don't address that, whether it's from low thyroid, high reverse T3, which actually blocks the thyroid, your chance of success could be very low, because the more you diet, the more it's going to lower your metabolism. So you can see that's not a successful strategy. And there's all these diets that come out, new fad diets, high fat, low carb. And, yeah, they work for usually about 30% of the people temporarily. But in the long haul, it's only about a 5% success. We'll talk why that is and what to do about it. So basically, if you're having difficulty losing weight, again, gain the weight back continuously. And each round of that, and we'll show studies on that, if you basically lose weight and you go back to normal eating, your metabolism still doesn't go back to the way to normal. Yep. So everyone's seeing that, just to be sure? They're good? Okay, so what we'll talk about, undiagnosed hypothyroidism, the TSH, how inaccurate that is. People go, the standard way is looking at your doctor will look at your TSH and basically say if your TSH is high, yeah, they'll treat you. If your TSH is low, they'll say you're hyper. If it's normal, it's normal. Why go through 4 years of residency and fellowship training to learn that simple thing and not deviate from it? I wish that were true. I wish it was that simple, but it's not. And so we'll talk about how to diagnose low thyroid. And also people are treated, they're like, yeah, I'm being treated for low thyroid, and they're on Synthroid. And we'll talk about why that doesn't work. About yo-yo dieting, again, as you basically diet, eat normally, you go multiple rounds of that, which most people have, what happens to your metabolism and to your thyroid levels. Thyroid hormone resistance, what does that mean? It means your levels may be fine, but there's no effect. So what really matters is the cellular effect of thyroid, not the serum levels, the actual rate-determining step, meaning what's the most important factor in how active your thyroid is transport into the cell. And it's a little too complicated for this lecture, but there's different transporters for T4 and T3. And what happens, the T3 transporter is, or the T4, is more sensitive to stress, inflammation, any chronic illness, so the T4 doesn't get into the cell. But it looks great in the serum, and the pituitary is different. So TSH is fine, T4 is fine, T3 is fine, but in the cell it's too low. And it's a huge concept. And so serum levels are a piece of information, but they aren't end all of anything, because that's not really what matters. What's in the serum? It matters what's inside the cell, and how do you test that? And we'll show how to actually test that. We'll talk about insulin resistance. Studies show if you have insulin resistance, if you have diabetes, metabolic syndrome, pre-diabetes, there's actually significant reduction in the T4 to T3 conversion. What does that mean? It means you're not activating your thyroid. And again, the thyroid levels look normal when people test it, but you have usually on average a 40% reduction in T3, which is active thyroid, to no metabolism. And unless you fix that, good luck on reversing your diabetes. And they give you actually diabetic meds that make you gain weight, and it's just a terrible strategy. We'll talk about leptin resistance and what leptin is. set point malfunction. And people may notice that their body keeps trying to go back to that same weight. Whatever you lose the weight, it goes back to that, so we'll talk about that. And then Mary will get into food choices, activity, and mindset. And again, if you tried everything to lose weight, and this is really how we're evolving now. Before, we survived really because we could store energy very well in multiple ways. So during times of famine, we could survive. Now we have the opposite problem that's working against us, that we can store energy. And you also look at, all these, high fructose corn sugar and all these chemicals and are actually blocking thyroid levels, lowering our metabolism, and causing us to now be an obese nation where, generations before it was a lack of food that was the problem. I just want to mention this in studies we're looking at. You go to your doctor, he says, oh yeah, I read all medical journals. But what these studies found, so New England Journal of Medicine and Annals of Internal Medicine show that most doctors are practicing 10 to 20 years behind what's available in the medical literature, okay? So why is that? One, doctors don't read medical journals. They don't. They don't have time. They say, oh yeah, I read them. They don't. They go to their conference once a year. They wait for the drug rep to bring in, X study, that's a newly approved drug. But they don't scour the journals for new studies or even old studies. They found it takes, on average, 17 years for a proven new concept to get adopted into mainstream medicine. Again, so why is that? One, they don't read medical studies, but two, the biggest reason is that if you give a doctor a study or 100 studies that shows what they're doing is wrong, they don't want to hear it. You don't tell me what I've been doing is wrong, my patients are fine. And that's what these studies show. People say, why doesn't my doctor know this? Well, he doesn't want to know it. So real quick, what does the thyroid do? It's really the gas pedal for your metabolism. Increases fat breakdown, improves brain function, prevents cardiovascular disease, prevents cancer. It really is, again, it stimulates the cell to basically function. And so here's how, a real quick endocrinology lesson. TRH, thyroid-releasing hormone produced in the hypothalamus in the brain, tells the pituitary to secrete thyroid-stimulating hormone, which then tells your thyroid in your neck to secrete T4, okay? But T4 doesn't do anything. It's inactive. Now, you hope it goes to T3, which is now active, but it can also go to reverse T3 down there to the left. And that happens with stress, inflammation, dieting, and what does reverse T3 do? It blocks the thyroid. So what happens is, instead of making the thyroid, if someone gives T4, especially if you're stressed or dieting, you're going to make reverse T3 and actually blocks the thyroid. So again, we're taught in medical school that thyroid's very easy. We're taught that if your T4 and T3 levels drop, the body senses it, the TSH increases. And then, so if your TSH is high, your thyroid's low. If it's low, your thyroid's high. If it's normal, you're normal. But the problem, that's not the problem. The problem is down here in the conversion. So you really want to look at the T3 reverse T3 ratio, or free T3. Symptoms I'll just go through quickly. Fatigue, depression. Again, we're talking about weight gain here. Cold extremities. But a lot of people will notice they have a lot of other symptoms as well. And it's also variable. Some people may just have difficulty losing weight. Other people may have fatigue and depression along with difficulty losing weight, or just hair loss. It depends on genetically which tissues are able to bring in the thyroid and which are having a difficult time. And women have significantly less thyroid receptors than men, so they're much more sensitive to small drops in thyroid levels. Where men, they can get dropped significantly and they don't have that many symptoms. Where women will certainly notice it much quicker. Poor concentration, poor memory, lack of sweating, PMS. Number of studies show that majority of women with PMS have low thyroid. When you do more specific testing, again, the TSH looks normal, so standard tests say, oh, you're fine. But if you do more intensive testing or more accurate testing for the thyroid, they're actually 50-80% are low. And giving thyroid really improves PMS. Poor motivation, water retention, migraines. So again, we talked about the standard ways to really just look at a TSH above 4, depending on the lab. A lot of studies are showing above 2.5, but again, it's looking at the wrong test. And so they're debating a test that is inaccurate. If your TSH is high, if it's above 2, you're low thyroid. But if it's normal, it does not mean you're normal. You will miss over 80% of people with low thyroid, especially if you have difficulty losing weight, diabetes, depression. All those things are, 90+% of people are low thyroid if you check the right test. We talked about reverse T3 actually blocking the thyroid. So if we infuse reverse T3 in you, what happens? Your metabolism will drop, basically because it's blocking the thyroid. And you'll hear that it's just an inactive metabolite, and that's not what the studies show. So let's look. So what happens when you diet? Just basically diet. Well, what happens to your, again, T4 to the active T3 conversion? This was a study published in the American Journal of Physiology, Endocrinology and Metabolism, found that 25 days of dieting reduced the T4 to T3 conversion by 50%. So just dieting for a month, you have 50% less active thyroid in the system. And the thing is, your doctor won't pick it up because they're just looking at TSH levels. And even if they do look at T4 and T3 levels, they'll say, oh, well, they're in normal range, even though the T3 dropped by 50%. It's an interesting study. They had people who were the same age, same weight, same body fat, same lean muscle size, and they checked their metabolism. But half the people had significantly dieted in the past. They found those people had 25% lower metabolism. So as I was saying, that people go, I've wrecked my metabolism, and people go, oh, yeah, sure you have. You stop eating Twinkies in the middle of the night. Well, basically we find over a majority of time they were right. Their metabolism is very low. So 25% lower on average is basically a difference of 500 calories a day, which will equate to half a pound to a pound a week if you eat normally. Other than that, you have to diet 500 calories a day less, or basically jog for an hour, or something intense exercise just to stay even. And so that it's significant. People just really, the low metabolism, the body starts trying to gain that weight back. It increases reverse T3, and then you go back to normal eating. It still doesn't go back to normal. And years later, it's not back to normal, the studies show. So again, yo-yo dieters especially. And so unless you do something about it, your success of weight loss, it's doomed. Because if every time you diet, your metabolism drops and stays lower, what's the chance of successful long-term weight loss? So here's a study. Now, this wasn't rats, but what they did, they had them lose weight basically and then eat again. They found that after 3 cycles of that, weight loss occurred at half the rate and was regained at 3 times the rate in the second cycle. So it really shows that people go, oh my gosh, as soon as I start eating normally, the weight just comes back on. And again, because the effect it has on the thyroid. So really what, kind of to summarize the thyroid, you can't rely on the TSH. You need more sophisticated blood tests to demonstrate a deficiency. Chronic dieting will lower that cellular thyroid activity. So best to measure the free T3, reverse T3 ratio should be greater than 2, or 0.2 depends on the units that are used. And all this information in detail is on the National Academy of Hypothyroidism site, and you can see all the studies associated with those as well. Let's talk about leptin for a second. So what is leptin? Leptin goes up when you gain weight. It tells the body, hey, we have enough stored energy. Stop storing energy. It lowers your appetite. It tells the body to increase metabolism, tells the body to increase thyroid, and to burn fat. And so what they found is that, though, basically when most people, especially women that have difficulty losing weight, have a leptin resistance. So what does that mean? The leptin goes up fine, but the brain doesn't see it. So the body thinks the brain thinks the body is starving. So basically it's always trying to gain the weight back. It's increasing appetite and cravings, and basically telling the body to store fat at all costs, basically lowering thyroid levels and lowering metabolism. So really it makes it so difficult to lose weight, again, with a leptin resistance, because your brain thinks your body's starving and telling it to store fat. So here's just a couple things. What do you do for leptin resistance? Well, it's interesting. If you lose weight, you'll get rid of leptin resistance. Actually, it will go away. But how do you lose weight if you have leptin resistance and low thyroid? So these are just a couple medications that we use for leptin resistance. And so if you're just easy way to check, if your leptin level is above 12, you have leptin resistance. The higher the leptin, the higher the resistance, like insulin. If you have insulin resistance, you have high insulin. So here's medications that we use. Basically, these are placebo, the yellow, versus the weight loss with using the medication. So Byetta, Symlin, Victoza, and there's now a time release by it as well. So here's Simlin. You can see the difference in weight. And they're used for people they're approved for diabetes, but you don't have to have diabetes to use them. They work very well in normal people that don't have diabetes but difficulty losing weight. And we've been doing this for years, and we got grief like, oh, they're treating off-label, and the studies are there. In fact, here's one that basically shows this is a meta-analysis. Basically, they take all the studies and say, hey, what do they show, and summarize them. And this present review provides evidence that treatment with these medications leads to weight loss in overweight or obese patients with or without type 2 diabetes. So it works regardless if you have type 2 diabetes, which is really an arbitrary number anyways. And, they've been out, these studies have been out for a long time, but again, the doctors, the endocrinologists don't read the studies. Let's talk about set point malfunction, again, what's really where the body just wants to go back to that weight. And we see it really in a lot of chronic fatigue syndrome, fibromyalgia. With aging, the body wants to stay at a higher weight. Medications that can really will sabotage your weight loss, antidepressants, anticonvulsants, or any of the medications for diabetes that increase insulin really make it difficult to lose weight. So basically things to do for that, thyroid, HCG, naltrexone. Now, naltrexone's interesting, and it is a medication that blocks the opioid receptor. So it's approved for people that go in the emergency room, they've overdosed on narcotics, you give it to them, reverses it. But what they found at very low dose, it's an immune modulator. So we use a lot for fibromyalgia, autoimmune disease, lupus. It works great and extremely safe. And at a higher dose, it works for weight loss, especially when combined with Wellbutrin. And that medication is basically will probably be out soon. It got FDA approval, but you can use it now. Both these medications the naltrexone has to be compounded because it's such a low dose. But again, all these are options for people. And here's a study showing the weight loss with the Wellbutrin and naltrexone, especially if someone's already on Wellbutrin or has depression. Heck, it's a good thing to try. Also notice decreased cravings. There's studies showing oral serotonin in weight loss. And there's a new medication will be out that it's a serotonin agonist that helps for weight. But we'll often give just straight serotonin for depression, but also works for weight. And I like it because you get the effects of antidepressants without the side effects, so the sexual side effects and all the insomnia and jitteriness and all that you can see. And HCG is kind of a hot thing, human clinic and atotropin. And all these things work for 4% of people. And if you read, they always say you have to do 500 calorie a day diet, which I don't recommend to do it because, again, it tells the body go in that starvation mode. So HCG works with a reasonable eating program as well. So kind of some things to naltrexone, Wellbutrin, things that are potentially. Phentermine actually can work. These are kind of the stimulant meds. HCG, you got to optimize your thyroid, or your chance of long-term success is just so low unless you fix your metabolism, fix your thyroid. Serotonin, we just talked about, Simlin and Victoza for the leptin resistance. Phentermine plus Topamax is just got approval. What they're doing now is there's, most money spent by the pharmaceutical companies is not in research and development. It used to be that. Now it's all marketing. And they'll just take a drug, take two old drugs, add them together, and that's their new drug. Much more cost effective, but there's nothing, it's just basically reinventing the wheel all the time. So, what can start on your thyroid? Really any stress, inflammation, depression. I mean, almost every single person with depression is low thyroid. But they tend to have a low TSH, so doctors think they're high. If anything, it's totally the opposite. And again, it goes through all the studies on the NEH site. So I'll turn that over now to Mary, and she'll go into a few other things.
Okay, thank you, Dr. Holtorf. That was fascinating information, and I hope people are finding it interesting. To learn about some of the physiology of the thyroid and some of the various things that you are working with, very cutting-edge approaches to weight loss and metabolic rehabilitation over at the Holtorf Medical Group. So what I wanted to just touch upon were what really can go wrong that slows down your thyroid and gets in the way of being able to lose weight. I know we have some veteran thyroid patients that are on the call who know everything there is to know about hypothyroidism, but I also know we have some newbies and some folks who are new to the subject who are wondering if their thyroid may be getting in the way of weight loss, but they don't yet have a diagnosis, so they're not really even sure what direction to go. So I wanted to kind of just give a little bit of background to help out some of those folks, and we'll get to some of the other information for the long-term folks who know all of this information like the back of their hand. But I just wanted to touch upon the fact that one of the first things that really can go wrong to slow down the thyroid is just general hypothyroidism itself. And hypothyroidism refers to the condition of the thyroid being incapable of producing enough hormone or incapable of producing any thyroid hormone at all. And thyroid hormone is our master, the thyroid is our master gland of metabolism and energy, and the hormone, its function is to go around the body and deliver oxygen and energy to every cell, tissue, gland, and organ in the body. So it is absolutely fundamental for us to stay alive to have thyroid hormone, but it's also a crucial part of metabolism and energy. So when the thyroid slows down for a variety of reasons, it really can wreak havoc on metabolism, energy, and ultimately on our ability to lose weight. One of the most common causes of that slowdown is autoimmune Hashimoto's disease. Big, long name, but the bottom line is it's when the thyroid gland starts to produce antibodies that attack the gland itself. So it's basically self-destructing the gland. This is an autoimmune disease where the immune system's turning on itself, and the gland can slow down and eventually become atrophied and underactive, and in some cases it'd be incapable of producing any hormone at all. Another way that people end up with a slowed down thyroid is they have radioactive iodine treatment, or they're taking anti-thyroid drugs as a treatment for Graves' disease and hyperthyroidism. So this is the opposite problem of Hashimoto's. This is when the thyroid becomes overactive, and the treatment for overactive thyroid tends to be either to use nuclear radiation to ablate it, which slows it down and deactivates it, or to give medications that slow it down to hyperthyroid levels. And then the other way that we tend to get a slowed down thyroid is surgical removal of all or part of the gland. So whether you've got thyroid nodules or thyroid cancer or Graves' hyperthyroidism that isn't responding to radioactive iodine or anti-thyroid drugs, when they're taking part or all of your thyroid out, it's very likely that it's going to end up slowing you down. So we're going to go jump in. We talked a bit about some of the various medications and supplements and things that we can do, but I wanted to just really go over, again, some of the steps to getting diagnosed properly and then moving forward into some of the different things that you can do to lose weight. So one of the interesting things about hypothyroidism is that 60 million Americans, by a lot of different estimates, that's 1 in 5, have thyroid problems. Most of those people are not diagnosed. Anywhere from 13 to 20 million Americans have a diagnosis. The numbers are kind of squishy at this point. It's hard to get hard numbers from the different groups that do these kinds of studies, but we know that 60 million have thyroid problems at least. There may be even more, and only anywhere from 13 to 20 million are diagnosed. So there's a lot of people walking around with an undiagnosed thyroid problem. Interestingly enough, about 2/3 of Americans are now overweight or obese. So if you think back to your old geometry class or your the basic Venn diagram, the two circles with the intersection, there's a big intersect between the number of people who are fighting obesity or overweight and the number of people who have an undiagnosed thyroid problem. Unfortunately, as Dr. Holtorf mentioned earlier, doctors tend to dismiss the importance and diminish the importance of the thyroid as a function of ability to affect your body's ability to lose weight and your metabolism. They kind of say, oh, you'll only gain a couple of pounds if you become hypothyroid. And for those of us who have been in the trenches ourselves with thyroid conditions or with thyroid patients, and I know Dr. Holtorf would agree, that could not be farther from the truth. A couple of pounds is a lucky thyroid patient. A lot of thyroid patients start putting on several pounds a week when their thyroid gets haywire, and it doesn't stop until they get their thyroid under control. So if you suspect that you have a thyroid problem, or you're trying to get diagnosed, or you are already starting the process, what do we need to look at? Well, a couple of basic tests that we want to always take a look at would be TSH, and keeping in mind that what is considered normal by labs and many endocrinologists is not considered normal by the more cutting-edge experts on metabolism like Dr. Holtorf. So levels above 2 are usually going to be pretty suspect, and even for some patients, levels above 1. We're also going to want to look at free T4 and free T3. These are the circulating thyroid hormones in the bloodstream, which tells us a lot about what's happening going through the bloodstream. We're going to want to look at thyroid peroxidase, or TPO antibodies, because that's going to tell us if you've got an incipient case of Hashimoto's developing, and that gives us a picture of whether there may be autoimmune thyroid disease. Even if all the other levels seem perfect, normal, optimized, etc., if that antibody level is very high, that's a sign of inflammation, and it can be a contributing factor to thyroid issues. And then there's the reverse T3. That's the type of T3 that's formed when the body is under stress. And the more the reverse T3 levels are elevated, the more likely you are to be dealing with adrenal stress and also some challenges with your weight as well. So if you are already being treated, so that list was for those people who are going out cold and starting from scratch. You want to make sure that you don't just get that TSH test from your doctor. You get that complete panel of tests, because otherwise you're not going to be able to get a really good picture of what's going on with your thyroid. For those of us who are already being tested or being treated, who are trying to get a handle on exactly what we're supposed to be doing as far as optimizing the thyroid, because that was one of the things that Dr. Holtorf mentioned, was optimizing the thyroid. So we want to really make sure that that TSH is lower end of the range, ideally below 2, and in many cases around 1 or even lower. So your doctor's going to talk to you about what that target is, but for most people they're not going to be able to lose weight if their TSH is 3, 4, and 5. The free T4 and free T3, this depends on you and the type of treatment that you're getting and the approaches and the medications that you're using. For example, if you're on a T3 medication, you may have a T4 that tends to be low, but generally for a lot of people who are on some combination of T4 and T3, they want to see the free T4 levels in the midpoint or higher of the normal range, and free T3, again, midpoint and higher, and ideally even on the higher end of that normal range, and reverse T3 within the normal range, lower end of the range, and if you take a look at the National Academy of Hypothyroidism and Holtorf Medical Group, there are a number of more in-depth papers that talk about the reverse T3, T3 ratios and how to optimize those as well. So we want to really take a look at all of those things. So if you're just getting, oh, your thyroid levels are normal from your doctor, that's not enough information. You need to be asking what the numbers are specifically. Now, whether you're just new to being diagnosed or you're already been diagnosed and you're looking to optimize your treatment at this point, let's take a quick look at what the different options are. And I want to start out by saying one size does not fit all with these medications. And the best medication for you is the one that safely and best helps you resolve your symptoms. So there is no one magic bullet, and I think if you ask Dr. Holtorf, if you ask me, if you ask most of the integrative doctors out there, they're going to say the best medication is the one that works best for my patient, and I'm going to figure out which one that is. But that's a trial and error process for a lot of patients to figure out which one's going to be the best. But the traditional one that most of the conventional doctors are giving is levothyroxine, which is a synthetic form of T4. Those are the drugs like Thyroid, Levoxyl. We have a new drug on the market called Thyroid. It's a capsule liquid hypoallergenic form of levothyroxine, so it doesn't include any cellulose, binders, fillers, dyes, etc. So some people who are sensitive to the lactose or the acacia or any of the dyes and fillers in Synthroid and some of the other pills are doing a little bit better with the Thyroid. It also allows you to drink coffee with your medication, which you should not be doing within an hour of taking any of the other T4 medications. The research out there, it does show, however, that the majority of patients tend to need the addition of T3. That's the second key hormone and the active hormone at the cellular level. So some people get it in the form of cytomel, which is the manufactured form of T3, or they get compounded time-released T3. Some patients, as I mentioned, are on a T3-only therapy. That would be typically a compounded time-released T3. That seems to work best for some patients. Not a huge number of them, but a small percentage of patients seem to function best with that particular protocol. Some patients really do best with compounded combinations of T4 and T3 in one pill. And then, of course, there's a subset of patients that do well with natural desiccated thyroid. These are the natural thyroid drugs, sometimes referred to as NDT, or often derogatorily as pig thyroid by some of the endocrinologists. These are the drugs like Nature-Throid, Armour, Acela, which is the generic here in the U.S., and Urfa, which is a brand of natural thyroid that comes from Canada. And those drugs have both T4, T3, and a variety of other nutrients and cofactors in it. So some patients seem to do better with the natural thyroid drugs compared to the synthetics. So which one will you do the best on? There is no way to predict that without having you try and start on a drug and then checking your symptoms, checking your numbers, and evaluating as you go. Dr. Holtorf touched upon some of these issues before, but just to give you just a quick recap, if you are gaining weight, so you've got your thyroid identified, you've gotten, let's say, either diagnosed or you're even being treated, and you've optimized your thyroid according to these kinds of numbers that we're talking about, and you've tried the different medications to get to the optimal levels to try to resolve symptoms and keep numbers in the optimal numbers, where you're still not able to lose weight, or you're gaining weight despite doing diet and exercise. So what do we do then? That's when we start to look for evidence of thyroid hormone resistance. So if you haven't had that reverse T3 tested, you're going to want to get that test added into the mix. And if you're not on a T3 therapy, you may need to look at T3 to help deal with that thyroid hormone resistance. You're going to want to check for insulin resistance. Dr. Holtorf mentioned that before. So we want to get that fasting glucose level. And levels above 100 may indicate a need for a low glycemic or low sugar diet, or even those medications. The type 2 diabetes medications can, in some cases, prevent progression to overt type 2 diabetes for some people who have metabolic syndrome or pre-diabetes, which can be predicted in some cases by elevated fasting glucose levels. You're also going to want to get that vitamin D checked. We hear a lot about vitamin D these days, but you don't always hear about the connection to weight loss. And vitamin D levels have to be optimized in order for the body to effectively lose weight. So a lot of practitioners really would like to see those levels at 50 or higher, and adding supplements when needed for the vitamin D levels. Dr. Holtorf mentioned leptin resistance, so we'll just remind people again, if you haven't had your leptin checked and you're struggling with weight loss, that's something that you may want to take a look at having measured. And if the levels are above 10, you got to start taking a look at it. And as Dr. Holtorf said, if the level's above 12, you have leptin resistance. There are medications that Dr. Holtorf mentioned. He also has some excellent supplements that can help with blood sugar and help to try to rebalance. There's also some dietary changes that can support helping to balance your leptin as well. Cutting the starchy and sweet carbohydrates, focusing on 3 meals a day instead of grazing all day long, minimal snacking, and not eating at night, allowing yourself enough time for fat burning to start to occur, sometimes can help support other efforts to counter leptin resistance. You're also going to want to take a look at the adrenals, and that can be measured with the 24-hour saliva cortisol test. And that test is going to be able to pick up on whether or not your adrenals, your body's stress mechanism, is operating optimally. And there are a variety of ways to address imbalances in the adrenals with dietary support, supplements, lifestyle changes, and, less commonly medications specifically to support the adrenals. Dr. Holtorf mentioned earlier some of the type 2 diabetes medications. The metformin and glucophage seem to be helpful for some people who have low levels of insulin resistance. The injectables, the Asymlin, the Byetta, the HCG, then the naltrexone. So there's a variety of medications. Keep in mind, though, you're probably not going to get these from your family doctor or your endocrinologist. You're really going to have to talk with an integrative hormone expert who's focusing on metabolism, thyroid, hormones, and weight loss. So it really is going to be a limited number of doctors in the country who understand how this works and have the capabilities to make those kinds of diagnoses and then properly prescribe the kinds of medications that may be helpful to patients. Supplements to think about, and this is one thing I do go into in much greater detail in my book and over at the Holtorf site that's maintained by the folks at Holtorf Medical Group. There are a variety of really excellent formulated formulations of a variety of different support supplements. But some of the ones that I tend to like, I like conjugated linoleic acid, CLA, tends to help with belly fat for some folks. The supplements Hoodia and Ervingia seem to work well for some people for appetite suppression. Now, keep in mind, supplements don't work the same for everybody. So one that might work for me might not do a thing for you, and vice versa. But it's a trial and error process, again, just like it is when we're trying to find the right thyroid meds. Cinnamon, but pure cinnamon in its pure form, not the fake cinnamon that you get in the little can at the store that, you know, comes at the spice rack. But real cinnamon can actually help to lower blood sugar. Selenium, which can in some cases help with autoimmunity, but you never want to take too much, no more than 400 micrograms a day. Melatonin in low doses has been shown to help with T4, T3 conversion and lowering blood sugar. Thyroid support supplements, but make sure that you're careful about iodine. You only want to take iodine if you need it, a supplemental iodine. So you want to take a look and make sure that the supplements you're taking have the right balances of things. And if you need iodine, which usually should be established by an iodine test, then you can add that into the mix. But don't just automatically jump right into iodine. And then, as I mentioned, the Holtorf have a thyroid support supplement. There's the various glucose support supplements, controls, craving control, Super Slim, and a variety of others that are nice combination supplements that include a variety of different ingredients that may be able to help with metabolism, energy, appetite, etc. Some of the things that I have talked about in talking with thousands of thyroid patients who try to lose weight, and many of the top doctors like Dr. Holtorf and others around the country who are dealing with thyroid patients trying to lose weight, is what types of things do we need to do food-wise to really help achieve weight loss. And one of the most important things that a lot of people find very helpful is to go gluten-free, to eliminate wheat and gluten products from the diet. And that is even if you don't have celiac disease or a wheat or gluten allergy. For some reason, there seems to be a sensitivity to these products that's more common in thyroid patients. And when they eliminate them, some people find that that is the one change they make that makes all the difference. I spoke with a woman the other day. All she did was cut the gluten out of her diet. She didn't cut anything else, and she lost 30 pounds in 3 months. So sometimes this is a huge change that can really make the difference. You also want to look at carbohydrate and glycemic control. And I think Dr. Holtorf and I are both on board with the idea that we don't want to eliminate carbohydrates completely. We don't want to go on the Atkins kind of diet. But the carbohydrates should be low glycemic. They should be low sugar. So you want to get the most of your carbohydrates from vegetables and a little bit of fruit in some cases. You may need to minimize or eliminate grains in some cases in order to effectively lose weight as a thyroid patient. You're going to want to emphasize low-fat proteins. That would be the lower-fat cuts of meat, poultry, fish. Beans can be a good low-fat source of protein. Vegetables, good fat. The good fats are found in fish, olive oil, coconut oil, avocados. And that really should be the bulk of your diet. So low-fat proteins, vegetables, and good fat. You want to watch the raw goitrogens. Those are the vegetables that can slow your thyroid down, which we love them. The broccoli and the kale and the cabbage, they're all fantastic, but you need to steam them or cook them slightly to get rid of the goitrogenic potential to slow your thyroid down. You want to be careful about too much calorie restriction. As Dr. Holtorf pointed out, when we drop those calories down, we start messing with the thyroid's ability to convert and function. So it's a careful balance between movement, diet, calorie cutting, and making sure we change the nature of the food. We also want to drink enough water. Some experts say you need to drink an ounce for every pound of body weight. That's a lot of water for some people. But so you work your way up to as much as you can drink in a day, but the water helps to flush out toxins. It helps to actually keep the body hydrated and helps with fat burning and metabolism. And then avoiding artificial sweeteners is also an important factor that can be very helpful for some people, especially if you're hitting a plateau. You may, and you're a diet soda person or you're using a lot of Splenda or something, you may want to eliminate it out of your diet and see if that helps at all with your weight loss and gets things moving a bit. Okay. Let's see. All right. Are we going back to where? Okay. Yes. All right. We're on. Okay. We're going to talk about movement a little bit. Movement is crucial. We're not going to be able to just lose weight as thyroid patients with simply making dietary changes. You will have to move to build muscle because muscle is more metabolically active than fat. So the more we can build muscle, the more we can help to raise our metabolism naturally. Some of the best exercises for muscle building would be working with weights, Pilates, or yoga, the types of things where you're actually using your own body as the weight. You can certainly do aerobics, which can help burn calories and raise the metabolism for short amounts of time, but you don't want to over-exercise because then you can cause adrenal stress, which raises cortisol levels, which actually then is defeating the purpose and working against your ability to lose weight. So I'm not a believer in the Jillian Michaels approach, which is that if you're not passing out, throwing up, or falling over, that it's not good enough exercise. I think exercise needs to be an exertion, but you shouldn't be sick or exhausted or on the couch for a day after exercising in order to survive it. Walking is an ideal exercise, but not strolling really slowly with the dog or walking around the mall looking in the windows. You really need to be, working up a sweat and moving. Lymphatic detoxing is especially good for people with thyroid issues. That's like rebounding, and again, good, race walking or fitness walking can be excellent for your lymphatic system and help clear out the toxins out of your system. I happen to have a very favorite exercise that I recommend to a lot of thyroid patients. It's called T-TAP. Has nothing to do with tap dancing. It's a mind-muscle activation program. It's very easy to do at any size or fitness level. It has tremendously good results for a lot of patients. I featured it in my book because I think it's so effective for thyroid patients. And you can try some exercises and see some free videos and things at their website, which is at t-tap.com, and we'll have links to that available as well. But that's one that I particularly recommend for thyroid patients. Then, the other thing that's so important is the mindset and self-talk. We don't want to talk negatively to ourselves about losing weight. So you really have to honor your body and feel good about yourself. You want to eat slowly and chew thoroughly. So this is not a stress activity. It needs to be done and calmly, as peacefully as possible, so we're not raising the stress hormones while we're eating. Don't eat while you're standing up, in bed, watching TV, reading, driving, on the computer, in the phone. This means your body doesn't even register that you've eaten. You don't get the satiety hormones released into the bloodstream, and you're hungry 5 minutes later. And then breathe through your meals. This helps the autonomic nervous system and activates hormones that help with digestion. One of my favorite books on the topic is The Slow Down Diet by Mark David. He's an integrative nutritionist. I highly recommend it. It's a short read. It goes around with me everywhere. It's a fantastic book. You're also going to want to address any emotional and stress eating. So if you are an emotional eater or a stress eater, we need to find something that's going to be an outlet for you for that stress. So that's yoga, breathing, religious services, meditation, or therapy in some cases. One of my favorite tools is Steve Gergovich's Self-Hypnosis Diet CD. I listen to it regularly, and I actually gave it to a girlfriend of mine who wanted to get off of chocolate. She listened to it for a few nights, and she was a smoker, and she stopped smoking. It wasn't even about smoking, but it helps you get your body focused on doing good things for yourself. So I love that CD. The other thing that you want to do is track and record what you're doing food-wise, exercise-wise. For some people, simply the act of writing down helps them cut calories and lose weight. Weigh yourself daily. I know they tell you not to do that, but that allows you to really see over time the ups and downs and what foods affect your body in a positive way and a negative way. If you know that every time you eat salmon and a big salad, you lose a pound the day after, well, that's good to know. That's something that can encourage you to eat better foods. And then probably the most important thing is to sleep. If you're sleeping less than 7 or 8 hours a night, you're probably not going to be able to lose weight no matter what you're doing. Because sleep is the time when we rebuild our stress hormones and our thyroid hormones, our growth hormone, and if you don't get enough sleep, your metabolism can basically shut down and slow down. So those are really the critical good habits, and I go into a lot more details on some of these specific habits and the mind-body issues in the Thyroid Diet Revolution book. But these, I think, were really the most important ones that I wanted to call out as really crucial for sharing with today's program. So that basically covers a lot of the section that I was going to be talking about. So, Jenny, are we going to go to some questions from folks?
Can I make just a couple comments?
Oh, sure.
And just, I totally agree with, what's the best thyroid preparation really is what works for you. And I usually start my presentation to doctors with that question. They kind of debate it, but really it is what works for the patient. And generally, again, there's exceptions to all this, but generally the sicker the patient, the more inflammation, chronic fatigue syndrome, depression will typically need more T3. Mary mentioned Graves' disease, which Graves and Hashimoto's are pretty much the same in that they both are antibodies attacking the thyroid, destroying the thyroid, but with Graves, the antibody happens to hit the thyroid receptor that stimulates the thyroid. So they go the opposite ways. And really, people have Graves' disease, and the doctor said, well, you either can nuke it or basically take it out. But the low-dose naltrexone we talked about can really, treat the immune dysfunction and reverse that. I can't tell you how many people we've had not having to get their thyroid nuked or taken out. Along with selenium can help. One study showed 40% reduction in antibodies. Testosterone, men don't get those autoimmune diseases as much as women. All those can be beneficial. Getting rid of food allergies also helps. Then if they ended up getting a thyroidectomy or getting their thyroid nuked, and the doctor typically put them on T4, oh my gosh, it's a huge part of our practice. The average weight gain's 20 pounds. And the doctor says, well, just stop eating. And again, they're not making any T3 without a thyroid, and giving T4 I think is really malpractice. But then the doctor may give a little 2.5 or 5 of cytomel and say, see, it didn't make a difference. Yeah, because the dose is way too low. And also regarding the Hashimoto's, people check the TPO and antithyroid globulin antibody. That's just 2 antibodies. There's a lot of other potential inflammation with thyroid. One study, they did thyroid biopsies in people who were just fatigued. And they found the majority had thyroid inflammation even though their antibodies were negative. Then they went back and gave all those people basically thyroid replacement, even though they were so-called normal because their TSH was normal, and they responded regardless of what their thyroid levels were. So you can have, again, thyroid dysfunction that doesn't show up. I want to talk a little about exercise. Again, over-exercising, especially in women, the body senses stress and lowers the thyroid. So again, you're fighting yourself by doing excessive exercise, especially in women. Guys can typically get away with it because the body doesn't sense as much stress with that. And where that level is different for each person. Mary mentioned sleep. Oh, very important. And studies show you're probably better off sleeping in than you are waking up early and exercising. That you'll actually get, better weight loss with that. Getting sleep is very tough because everyone's, type A and you got so many things to do. But really a key is to get good sleep. If you don't sleep, you get insulin resistance, low thyroid, all those things. And so a lot of this, information. I only went through a lot of, a lot of topics and kind of, threw a lot of new topics at you and new information. But it's all in National Academy of Hypothyroidism, and I really recommend. All Mary's books are just so great, and it lays it out in an understandable fashion and well-researched. So I recommend all those as a great resource. So that was just my 2 cents there at the end.
Do we have a few moments for a couple of questions?
Sure.
Absolutely.
Okay, great. And we had a couple of people mention this, and I think Mary Shomon had an answer to this, and it's something that I don't know nothing about, so hopefully I'm saying it correctly. Ervangia, is Ervangia a solution to leptin resistance for a hypothyroid person?
Right. Ervangia is a supplement that is derived from a plant, I think it's in Africa, and they have done some studies with it that have shown that it helps with lowering insulin levels. It can lower the glucose levels a bit and can affect belly fat a bit, lowers appetite a bit. And there were some studies, and it's not been intensively studied, but there have been some studies that suggested that it may help lower leptin levels slightly. So it's one of those trial and error types of supplements. I don't think it's a slam dunk for everyone, and there may be people who have just minor issues who try it and find that it's enough. For people that have massive leptin resistance, I don't think that it's probably going to be something that's going to hold its own against that. They probably need to be doing more potent things like Dr. Holtorf was talking about. But for people who are just mildly elevated leptin or who are just struggling with weight loss, it's one supplement that's considered safe that may be worth trying for maybe 2 or 3 month period to see if you get some results with it.
Great. Thank you, Mary. I have another question from Donna. She has a twofold question on HCG and was wondering if you've done HCG in the past and it's worked but gained some weight back, is it safe to do it again? And also, is HCG something that can help reset the hypothalamus to help the thyroid? Hypothalamus, I'm sorry, and help the thyroid.
Yeah, it is very safe. And you look at, on the show, the doctors and talk about HCG, and then that OB is like, oh, it's studies show it blood clots. No, that's when you use it for fertility and you're raising estrogen levels. Then that's when, you wouldn't want to do that. The dose you're using for weight loss is so small. Studies show exceedingly safe. Yes, it's very safe to do it again. There may be some evidence that you tend to get tolerant to it a little bit, so sometimes taking a break and then restarting it. But, yeah, it's really safe to go back to if it's working. It doesn't work for everyone, but it works for a good % of people.
Thank you, Dr. Holtorf. And we have Shirley who's asking a twofold question, if there's a difference between Synthroid or Levoxyl, and might those prevent weight loss?
You want me to take that one, Dr. Holtorf?
Sure.
Okay. Synthroid and Levoxyl are both brand names of the levothyroxine, which is the synthetic T4 medication that a lot of the conventional doctors use as their primary treatment for hypothyroidism. So the basic core ingredient, the levothyroxine, is the same for both drugs. But there are some very big differences between Synthroid and Levoxyl. First of all, Synthroid has lactose in it, so people who are lactose intolerant can react to the lactose that's an ingredient in the Synthroid. Synthroid also has acacia in it, and acacia is derived from a tree bark, and so some people who have pollen and tree allergies seem to have a sensitivity to the Synthroid. Synthroid is also manufactured as a very hard pill, so it's not that easily digested. So for some people who have very rapid transit through their digestive system, the Synthroid can come in and out, and it may not completely dissolve as it transits through the intestines. Whereas Levoxyl is the opposite. It's almost powdery. And they actually tell you if you're taking Levoxyl to take it with a big glass of water and drink the water down fast so that you're getting all the benefit of the medication while it's dissolving, because it typically dissolves almost before it gets down your throat. Levoxyl and Synthroid also have some different dyes and fillers. Some of them have cellulose in their formulations. Some of them don't. So you want to always look at the ingredients list of the two if you have sensitivity to any of the ingredients. But generally, as far as the action in the body, the levothyroxine T4 synthetic form, which is meant to go and help support the thyroid's, the need for thyroid hormone, they basically are very similar. Support the thyroid's, the need for thyroid hormone, they basically are very similar.
That's weird.
Somebody might have turned on some speakers.
Yeah, that may be it.
That's weird.
Somebody might have turned on some speakers.
Yeah, that may be it.
There we go. Much better. Dr. Holtorf, are you there?
Yep.
Great. We'll ask a couple more questions, and then we'll close for the evening. We have a question from Jackie, and wants to know if hypothyroidism causes edema, or can it cause edema?
Yeah, Mary, you want to take that?
Sure, yeah. Edema is the medical terminology for swelling and puffiness. And yes, absolutely, hypothyroidism can cause edema, swelling, puffiness in a variety of different places. It can cause it in your hands, in your feet, especially in the face, the cheeks, under the eyes, around the eyes, the eyelids area, and in some cases there's also even internal swelling and puffiness. So some people find that they have problems with swelling in the belly, puffiness in the stomach area. So there's a variety of different locations where we see it, but yes, absolutely it's associated with hypothyroidism. It's a very common symptom of hypothyroidism.
Thank you, Mary. We appreciate that. And we have a question from Liz who would like to know if Hashimoto's requires different medication than regular hypothyroidism.
And, you know, with Hashimoto's, again, it's just one reason to have primary hypothyroidism where the thyroid's low. The other things that we talked about basically are a problem. The thyroid's producing enough thyroid, but it's in basically the conversion, getting into the cell, high reverse T3. So basically at the cellular level, you have a thyroid problem. So with Hashimoto's, you also, that inflammation will increase reverse T3, so it kind of becomes a vicious cycle. But it's one reason to have low thyroid where, again, the primary, where the thyroid isn't working and you've killed off some of your thyroid. Now, what happens, too, if someone has severe Hashimoto's, as you're killing off the thyroid's dumping, the cells are dying and dumping into the system. So they can have very large swings as the antibodies go up or the inflammation spikes. The thyroid's getting killed off, but during that time, it's now the cells are dumping thyroid into the system. So they're actually high for a while, then low. So one way what you want to really do is calm that down, because they're going up and down on their dose because too much, too little. Again, with the low-dose naltrexone we talked about, selenium, giving testosterone, progesterone. Estrogen tends to make it worse. Women get it more often than men. So balancing the estrogen with progesterone and testosterone are some ways you really want to knock those antibodies down. Otherwise, you're just going to be going up and down and constantly changing the dose.
Thank you, Dr. Holtorf. We'll have time for one or two more questions before we end this evening. Kim has a question and wants to know if she has to go to an endocrinologist to get a doctor to listen to her about having or trying other options like T3. What other types of doctors can we go to if endocrinologists won't listen?
Can I take this one?
Take that one.
Absolutely not an endocrinologist, to be honest, because endocrinologists are, their specialization is the endocrine system. And if you have thyroid cancer or you need a thyroidectomy or you have Graves' disease and need radioactive iodine, then you definitely want to see an endocrinologist. And they're very good with the technical aspects of the gland itself and, dealing with the structural issues and the structural problems. But when it comes to balancing the hormones and dealing with hypothyroidism and its myriad symptoms, that is not the strength of, I would say, 99.9% of the endocrinologists out there. First of all, there's a shortage of them, so it takes forever to get in to see them. They're extremely hard to get booked. Some people wait 8, 9 months, a year to get to see them. If you do see them, you might get 5 minutes, 7 minutes if you're lucky, and they are very conventional. They're going to be looking at TSH tests. A lot of them aren't going to even bother with the free T4 or the free T3 or the antibodies. And most of them have just come from the Synthroid golf tournament, and so they're not going to be very interested in turning around and thinking about utilizing a T3 medication or a natural thyroid, and they absolutely have no training, knowledge, or understanding of some of these various issues like thyroid hormone resistance, the leptin resistance, the metabolic set point resistance issues, hypothalamic resistance. That is going to be like a foreign language to them. So the optimal kind of doctor is really going to be an integrative physician with an expertise in thyroid hormone balance. In some cases, there's some bariatric or weight loss physicians who have taken a special interest in hormones and thyroid and metabolism, but it really has to be somebody who understands metabolism, understands hormones and thyroid, and can really delve in and understand and learn, and maybe not doesn't know all the things that Dr. Holtorf and his folks know, but is willing to take a look at some of those papers and study them and give some things a try.
Mary, thank you very much.
I totally agree with that. I mean, they're not trained to use T3, so in their mind, because they don't know how to do it, no one needs it. So
exactly.
That's you get in. If your TSH is normal, despite all the studies, hundreds of studies showing it's not an accurate test, they typically won't treat you. Or to use T3 and the studies show you need T3. So, yeah.
Well, thank you very much. I want to thank Dr. Kent Holtorf and Mary Shomon for this great presentation this evening. Thank you very much for joining us. We will have this presentation available on nahypothyroidism.org and holtorfmed.com tomorrow. Dr. Holtorf and Mary, any last closing words for us?
Well, first of all, I wanted to say thanks to everyone who joined us tonight, and sorry about the technical issues in the beginning, but hopefully people will be able to hear the recording and look at the slides at their leisure and take a more in-depth look at things when they have a chance. And I just wanted to invite people to visit the About.com site, where we have a wonderful article called Is Your Thyroid Making You Fat?, which was an interview I did with Kent Holtorf a little while back, discussing some of these issues in greater depth. And I also wanted to let people know that Dr. Holtorf was one of the key people that I interviewed and consulted with in writing the new edition of my book, The Thyroid Diet Revolution. So if you want to really get into the meat and potatoes, pun intended, of these types of things that we were talking about, the leptin issues, the metabolic resistance issues, I had a really great opportunity to get a lot of good information put together from Dr. Holtorf and from a number of other colleagues of his who are very smart on this. So for folks who want a lot more in-depth information and some guidelines, I would suggest that you take a look at that book as well, and you can see the website, which is thyroiddietrevolution.com.
Great. I just want to say thank you, everyone, and really thank you for taking an active interest in your health. And I think so much now patients just go, oh, my doctor says do this, they go to their doctor, and they just don't question it. You know, you need to really take an active role now. The way healthcare is going, it's becoming mass medicine. You get 5 or 6 minutes with the doctor, and really you just get poor care, and your quality of life goes down. So you really can't rely on that anymore. And I just love the fact that we had a lot of people on tonight, basically making the effort to increase your quality of life and find out, hey, what really can I do to improve my health and the quality of life. So hopefully gave you some useful information and as a starting point as well. And again, a lot of the resources that Mary just talked about to follow up on that. And you can, on NIH site, you can print out all the studies for your doctor. Heck, give them to you. Here you go. Here's 200 studies saying giving me T4 doesn't work very well. And Mary's books are just fabulous, and her About.com site. So a lot of information to follow up because we present with you a lot of stuff. So and again, a lot of this is new to doctors, not let alone patients. So again, just appreciate the fact that you guys are on the call and taking an active interest.
Thank you very much, everyone. Have a great evening.
Great. Thanks a lot.
Thank you.
Bye-bye.